Hello, my name is Ravi Vij. I'm from My Cancer Haven, and I'm here today with one of the thought leaders in non-Hodgkin's lymphoma, Dr. Brad Kahl, professor of medicine at Washington University School of Medicine. He heads the lymphoma subcommittee at ECOG, and which is a large cooperative group, among other large number of commitments that he has at a national level in lymphoma. So I'm really uh, pleased that he agreed to today talk to us about major development in the last several months in non-Hodgkin's lymphoma bispecific antibodies. Welcome, Brad.
Thanks for having me, Ravi.
So, Brad, I guess you in lymphoma were the pioneers of actually antibody therapy in non-Hodgkin's lymphoma. I remember when I was a trainee, actually, that the first monoclonal antibody rituximab got approved, and that was the first time anything like that got approved in any cancer. Since then, obviously, it's happened a lot. But can you give the patients a little bit of a flavor for what are the kinds of antibodies that are used in lymphoma, and then we'll come down to really the bispecifics and a more detailed discussion on that issue.
Sure. So, right, I still remember the rituximab approval back in the late 90s. I think you and I were training at the exact same time. And, we were thrilled to have a non-chemotherapy option for lymphoma patients. And the way I explain it to patients is rituximab is it's a monoclonal antibody, which is a protein. Our bodies make antibodies to help us fight off infections. Well, this is an antibody produced in a lab, and it's infused into the patient's body, and it's designed so that the antibody sticks to the tumor cells. And when it does that, it tries to trick the patient's immune system into fighting the cancer. And it works pretty well. We learned over the years that rituximab by itself doesn't work terribly well against aggressive cancers or cancers that are growing fast, dividing rapidly. And we knew that if we were going to take advantage of antibody-based therapy in aggressive lymphomas like diffuse large B-cell lymphoma, the antibody strategy would need to be modified. So there have been a number of ways to try to make antibody-based therapy more potent. And the slide here depicts, many of those ways. I'll just highlight a couple. We see the box labeled radioimmunotherapy. And so tagging a radioactive particle to the antibody was shown to be slightly more beneficial or slightly more potent than just giving a naked antibody like rituximab, but still didn't really achieve the kind of results we were hoping for in diffuse large B-cell lymphoma. At the bottom of the slide, we see antibody drug conjugates listed, and there's a number of examples. And this is a scenario where literally a chemotherapy drug is attached to the monoclonal antibody. And then, so what you're relying on is the antibody to take the chemo drug to the tumor cell. And then you want the tumor cell to take that molecule inside. It's almost like a Trojan horse approach to trying to kill the cancer cell. We're trying to sneak the chemotherapy drug into the cancer cell. And by attaching the chemotherapy drug to the antibody, you can deliver the chemotherapy in a more targeted way so that the chemo drug is going more to the cancer cells and less to the patient's body. So there's numerous examples now of antibody drug conjugates in diffuse large B-cell lymphoma that have good activity that we use routinely in the clinic. But then the biggest development in the last 12 months has been the FDA approval of what are called bispecific monoclonal antibodies. That's shown at the bottom left of this cartoon. So bispecific monoclonal antibody has two jobs. It wants to stick to the cancer cell. So one element of that antibody will stick to the cancer cell, But the other element of the antibody will literally try to stick to the patient's T cells. T cells are cells of the immune system that have some natural cancer fighting ability, but because the cancer came from within that patient, those T cells don't attack the cancer. But if you add in a bispecific monoclonal antibody, you can literally, again, trick the immune system into fighting the cancer. And what we've learned is that these bispecific monoclonal antibodies are much more effective at tricking the immune system than a naked antibody is. And so we're very excited now to have the approval of 3 different bispecific monoclonal antibodies in the last 12 months in the field of lymphoma.
So that's obviously exciting times. And now we'll just talk through these bispecific antibodies. So first of all, as far as diffuse large B-cell lymphoma goes, we have got the approval of 2. And could you just walk us through what these are currently approved for, and also how these are tolerated and given to patients?
Absolutely. So the first approval in diffuse large B-cell lymphoma was the one on the right called epcoritamab. And so this is a bispecific monoclonal antibody. It was approved in the spring of 2023 for patients with relapsed or refractory diffuse large B-cell lymphoma who've been through at least 2 prior lines of therapy. And the drug epcoritamab is given as a subcutaneous injection. So it's an injection under the skin, and those tend to be quicker than an intravenous infusion. So that's kind of nice in terms of how much time the patient needs to spend at the office. And the dosing schedule is a little complicated, like it is for all of these bispecific monoclonal antibodies. Patients have to come in on the very first day and get a very tiny dose of the medicine, because as the medicine is circulating in the body, it can stimulate the immune system too rapidly. And if it does that, patients are at risk for this complication called cytokine release syndrome. That's when you're just activating these T cells too vigorously and too rapidly. And when that cytokine release syndrome happens, patients can have complications. They might feel like they have the flu, because that's what happens when you have a bad infection. It's your immune system really responding that makes you feel so crummy. They can have fevers. They can have a rapid heart rate. They can even have low blood pressure. So we have to take this possibility of the cytokine release syndrome seriously. And what we learned in the development of these drugs is that if you step up the dosing, so start with the baby dose, and then another baby dose a week later, and then you wait till the 3rd week to give the full dose, then the whole risk for cytokine release syndrome is greatly diminished. So that's the way epcoritamab is given, a subcutaneous injection, baby dose on day 1 of cycle 1, another baby dose on day 8 of cycle 1, and then the patients on day 15 of cycle 1 get the first full dose. And that's when there's still the biggest risk for the cytokine release syndrome. And so the recommendation is to hospitalize patients for about 24 hours, just in case there is the development of cytokine release syndrome. Fortunately, usually there isn't, and even if it does happen, usually it's mild. But just to be safe with the rollout of these drugs, they're recommending 1 short hospitalization for observation. And then this epcoritamab drug is given every 2 weeks, and it's meant to be given indefinitely, so there's no stop date to the treatment. So one advantage to epcoritamab is it's subcutaneous, but one disadvantage is it's meant to be given indefinitely. So that'll bring us to the second approval in diffuse large B-cell lymphoma. That was approved a couple of months later, and that's this drug glofitamab. Same idea, a bispecific monoclonal antibody. So one end will stick to the tumor cell, the other end will stick to T cells, trying to trick the T cells into killing the malignant B cells. And this drug also needs to do a stepped up dosing strategy to reduce the risk of cytokine release syndrome. So actually on day 1 of cycle 1, patients actually get a separate drug called obinutuzumab that helps deplete the blood of circulating B cells, and that reduces the cytokine release syndrome risk. And then the patients come back a week later and they get a baby dose, and then they come back a week later and then they get a bigger dose, and that's when the risk for the cytokine release syndrome really kicks in. So also on the day 15 dose for glofitamab is the recommended brief hospitalization for observation. And then when patients come back for the next dose, they get the first full dose. And then glofitamab is just given every 3 weeks for a total of 12 doses. So glofitamab has a stop date to the treatment, which is nice. It is an intravenous drug, however, so the patients, while they're getting the drug, they're often at the doctor's office longer because it can take a few hours to get the infusion in. Both of the drugs work very well. They have a overall response rate between 50 and 60% and a complete response rate, meaning the disease goes completely into remission, of 40%. So 4 out of 10 patients who get either one of these drugs will go into complete remission. And if you look at the data, the majority of these remissions are holding at 1 year, and they seem to be holding at 2 years. We don't have 3 and 4 year follow-up data yet because the drugs are too new to know what proportion of patients that go into complete remission will be staying in remission 3 years out, 4 years out. But the data looks very good at 12 months and 24 months.
And currently, these are meant to be given for people who have had multiple lines of treatment, multiple other treatments before?
Both drugs are approved for patients who have had at least 2 prior lines of therapy. So patients must have been through a frontline treatment and a second-line treatment. If the disease comes back after a second-line treatment, then both of these drugs become options for those patients.
And then you mentioned there was a third one approved as well. Could you tell us about this bispecific?
Sure. So this drug is called mosunetuzumab, and this one is approved for follicular lymphoma, so different lymphoma. This approval occurred in December of 2022, so almost a year ago. And similar to the other drugs, it's a bispecific monoclonal antibody. Will bind to the tumor cells, will bind to T cells, and try to trick the T cells into killing the B cells. Mosunetuzumab is a very nice option for patients with follicular lymphoma. It's given intravenously, like glofitamab. It utilizes a stepped up dosing strategy. So cycle 1, day 1, patients get a baby dose. A week later, they come back, get another baby dose. And then on day 15 of the first cycle, they get the first full dose. And then it's given every 3 weeks. Just come in and get a big dose every 3 weeks, just a couple hours in clinic to get the infusion. There is some risk for cytokine release syndrome with this particular bispecific, but the risk isn't quite as high as it is with the first 2 that I mentioned. So there's no required hospitalizations for this product. It can just be done outpatient. And the way the dosing strategy works is once you're on the every 3 week schedule, you do an assessment, and if the patient's in a complete remission, you can stop it after 8 treatments. And if they're not in a complete remission, but they're responding, you can give it up to 17 treatments. So it is fixed duration therapy. There is a stop date. And the data for this drug looks really good too. Overall response rate of 78%. So 8 out of 10 patients will go into some kind of remission, and 6 out of 10 will be complete remissions. So 60% complete response rate. And if you look out at 2 years, about 6 out of 10 patients are maintaining that remission at 2 years. We don't really have 3 and 4 year data with this product either because it's too new, but looking good with 2 year follow-up.
Once again, meant for people who've had a number of other treatments beforehand?
Correct. It's approved for follicular lymphoma patients who have had at least 2 prior lines of systemic therapy.
So you do have a wealth of options in lymphomas, both for diffuse large B-cell lymphoma and follicular lymphoma. And in both of these, another major advance has been cellular therapy, CAR T-cell therapy. So how do you, in diffuse large B-cell lymphoma and in follicular lymphoma, choose which to use?
Great question. And all of these things are pretty new to the field. And I think some of this still needs to be sorted out with additional study. But I would say, in the fall of 2023, the current thinking is if you're a patient with diffuse large B-cell lymphoma who's eligible for either one of these strategies, for most patients, option A is going to be the CAR T-cell strategy because we believe it has curative potential. And I say that because we have longer follow-up with CAR T cells now, and where we see patients who are holding their remissions 3 years, 4 years, 5 years after receiving the therapy, which makes us think they're probably cured. And we don't know yet if the bispecific antibodies have the ability to cure patients yet in diffuse large B-cell lymphoma. So for right now, we would favor picking a therapy with curative intent over a therapy where we're just not sure if it has curative ability. Now, if a patient can't get CAR T cells for some reason, or maybe the disease returns after they have received CAR T cell therapy, then the bispecific antibodies are an excellent choice for that patient. Now, follicular lymphoma is a different scenario. We do have approved CAR T products in follicular, but we don't know if the CAR T products in follicular really have the ability to cure follicular lymphoma. It's harder to prove cure in follicular lymphoma because the disease has a long natural history and you can see relapses after 5 years and 10 years. And we don't have long follow-up for the CAR T cells in follicular lymphoma. We have 2 and 3 year data, but we don't have 4 and 5 year data. And there are some risks associated with CAR T cell therapies. There's some risk for the cytokine release syndrome that I mentioned. People often need to be hospitalized when they receive CAR T cell therapy. There's some risk for some worrisome neurologic toxicity with CAR T cell therapy. So I think for follicular lymphoma, this is my guess, for most patients, bispecific antibodies will be preferred because they're simpler and safer. And CAR Ts would come in after bispecifics for most patients. There will be exceptions to that. There might be some follicular lymphoma patients, younger patients, who are getting disappointing remissions to good therapy where you might suddenly favor CAR T over bispecifics. But my sense is for right now, bispecifics are more likely to be selected for follicular lymphoma than a CAR T product. But again, that's just based upon available data. And that statement I just made could change over time as the data from these studies evolves.
And can CAR Ts and bispecifics be given to patients in their community oncologist offices, or are one or more or both of these needing a large academic hospital presence?
Right now, CAR T cell therapy is pretty much limited to large academic centers or a few very select, very large community practices with really good ancillary services. But for the most part, CAR T cells are limited to academic centers because logistically administering CAR T cells is very, very complicated. The bispecifics can be administered anywhere, including a community oncology office. I think the community oncologists who have not administered just need to get comfortable with the management of the cytokine release syndrome, which I think they can with a little bit of education and a little bit of experience. But in theory, a bispecific antibody could and should be able to give in any community oncology office.
Well, I really thank you, Brad, for that synopsis of these exciting new developments in lymphoma. And I think that there are several more bispecifics on the way, and there will be moving into earlier lines of treatment for patients as well. So I think this era is just beginning, is it not?
This era is just beginning, and I think we're going to see lots of really outstanding developments in these two areas in the next several years.
Well, thank you very much. I really appreciate you taking the time to educate the patient community about this exciting development. And you're doing some of the leading work in this area. And I wish you all the success to get even better treatments out for the patients in the years to come.
Thanks for having me today, Ravi.
Thank you.